Good morning, everyone. I hope you're having a good day or evening or afternoon, wherever you are. My name is Mara Quesada. I will be moderating this session entitled Putting Meaningful Engagement in Research. So we have the next hour to discuss the involvement of communities in research relation to drug use. And we have two speakers with us who I will be introducing in a few minutes. Okay, so let's start. This session will delve into the experiences of our speakers in working with the communities and learning about the experiences of communities directly in their research work in relation to drugs. Our first speaker is Dr. Dan um, Ciccarone, I hope I pronounced that right. He is a medical practitioner, a scholar, and a harm reduction advocate. Dr. Dan is a certified clinician in family medicine and addiction medicine, as well as a professor of family community medicine at the University of California in San Francisco. So he has a lot of experience in working with communities in relation to substance abuse in his ethnographic research background, as well as in his clinical practice related to harm reduction technology. So please welcome Dr. Dan Ciccarone.
Hi, everyone. My name is Dan Ciccarone, and I'm excited and honored to be here today at the Philippines Harm Reduction Summit. Thank you to the organizers, Inez and others, for inviting me today. I'd like to present my work on public health research with persons who use drugs. Let me use the example of the U.S. overdose crisis that's happening in the United States right now, where drug overdoses deaths due to drug overdoses have exceeded those due to car accidents, gun violence, and even HIV at the height of the 1990s HIV epidemic. This is a public health catastrophe. Yet, how do we know what we know about it? To do this, to get this understanding, we have to do public health research. This helps us get the depth and the breadth of a problem. And with this understanding, we can develop interventions, whether those interventions are policy level or clinical interventions, perhaps prevention, for example, harm reduction interventions. And I'd like to think of public health research as becoming in these two buckets. One is quantitative research and the other is qualitative research. On the quantitative side, we have the discipline of epidemiology. This gives you the breadth or the magnitude, scope of a problem. It's numbers-based research, and it helps answer questions such as how much, where is the problem worse, when did it begin, and what are the trends in this problem? In general, I think of it as the view from 10,000 feet, from high up looking down. Now, qualitative research is much more intimate than that. This is the discipline of anthropology or sociology. And here we're looking for more depth. Instead of breadth, we're looking for depth. We want context of a problem. We want to tell stories instead of numerical answers. Anthropological research can give us something that epidemiological research can't give us. Instead of answers of how much or where, we get questions answered such as how did this happen? Why did it happen the way it did? The how and why questions cannot be approached by epidemiology. Qualitative research helps us understand, instead of this large perspective, it helps us understand perspectives on the ground. Let me show you this in pictures. Public health, again, 10,000-foot perspective is like looking at a map from high up, a city from high up. Here we have a map of Philadelphia in the state of Pennsylvania in the eastern United States. And we see the size of Philadelphia. We see its relationships to a river, its relationships to Green Mountains, relationships to other cities. If epidemiology is good, it can get down to smaller districts such as neighborhoods or zip codes. But if you really want to understand the perspective of the street, you have to use anthropology. This is where the anthropologist thrives, understanding people and their lived experience and their social experience. Getting back to our example of the US overdose epidemic, what's driving the overdose epidemic right now is the class of drugs called opioids. And this is coming out as a triple wave epidemic where deaths due to the prescription pills of opioids, natural and semi-synthetics, have been going on for about 20 years, reaching a peak around 2016 and then declining a bit. But then, interestingly enough, heroin came in as the next wave of overdose. This is an illicit opioid, obviously. Deaths start to pick up around 2011. They exceed the number of deaths due to the prescription pills and then also begin to level off. And the third and deadliest wave of the opioid epidemic, the triple wave, is the third wave, which is that due to synthetic opioids such as fentanyl, fentanyl analogs, and other non-fentanyl synthetics. This wave keeps going up. If we look at the latest data we have as of middle of 2020, last year, we see this curve continuing to rise into the sky. And so our epidemiology, our numbers-based philosophy, tells us how bad it is. It tells us that this overdose phenomenon is happening in a triple wave. It can tell us that the overdoses have been worse in the third wave, that due to fentanyls, in U.S. regions of the Northeast and the Midwest, all the way down the Atlantic seaboard to Florida. It can also tell us about the age distribution of who's affected, that we have a bimodal distribution involving both young people, young adults in their 20s, but also those over 45. But what do the numbers not tell us? They don't tell us why fentanyl. How did it come about? Why did it happen now? They don't tell us anything about the transitions between these three waves, where there are actually individuals who are going from pills and migrating to heroin who then discovered or got exposed to fentanyl. We're individuals moving along these three waves. They don't tell us how people are thinking about fentanyl. Do they like it? Can they perceive it? Do they know what it is? Do they want more of it? Do they want less of it? They're also not telling us how people are adapting to fentanyl. This is crucial because I'm going to show you that adaptation, in this case, can be turned into interventions. The work I'm going to show you briefly comes from the Heroin Transition Study. This is my study. It's funded by the National Institute of Drug Abuse in the United States. It's a mixed method study. I like numbers and stories, so I'm going to put in my studies, but I'm going to focus on the qualitative part of this research study. Our qualitative study aims are to go to hotspots, places where the drug supply is changing toward this new drug, this new phenomenon called fentanyl. We've been to places like Baltimore, Maryland. We've been to the south, the southern part of Appalachia, Charleston, West Virginia, for example. And our aims are to understand the lived experience of the experts themselves. And what I mean by experts is I mean the folks who are using the drug. What is their lived experience? What is their knowledge, perception, attitude around this new drug we're calling fentanyl? In order to do this, this is my philosophical slide, if you will. In order to do this, we need to engage people. In order to engage them, we simply spend time with them. We treat them like they're experts. We trust them by listening to their expertise. And as we build trust, as we take their perspective seriously, they return that. The rapport and the trust building allows us to engage more with them. It allows us to engage with their friends, their peers. We show that we care. We don't judge them. We care about what their experience has been. And then as they increasingly invite us into their community, we meet their peers, we get peer referrals, we get collective insights then, not just individual insights, but social insights. And we share those back to the community, which is why in this process of sharing back, we've been invited back to West Virginia 4 times. We've been invited to be in Baltimore, we've been there 3 times, et cetera, et cetera. So how do we do this? Just briefly, we've written a chapter now on methods. If you're interested in us, have a TEDx talk on our methods. But here we are, we're having a team meeting on our way either before or after going to a coffee shop, because every morning has to start with coffee or some caffeinated beverage. This is my current team going from left to right. We have Eliza, Mary, Jeff, and Fernando. You see we're diverse in terms of gender. Fernando is Spanish speaking, so he allows us access to that community. As I've mentioned already, we spend time with people, a lot of time. It could be a single interview. It could be multiple interviews spread out over days. We follow people around. They follow us around. Once they get curious about what we're doing, we spend more time with them. We can meet them in public places like a plaza. We can meet them in their living room. We sometimes do interviews in cars. You see, this is George, another member of the team. There's a camera there with a fuzzy microphone. The person's in the back seat being interviewed. We meet people in the alleyways and the railroad tracks and more dangerous or challenging parts of town. For example, here we're interviewing someone in the back of an abandoned factory. And sometimes we're sort of out and about with our equipment and our cameras and our microphones are sometimes more discreet, depending on what the person we're interviewing is okay with or wants. Because fentanyl is a new drug, we're interested in it. How is it packaged? What does it look like in solid forms? How does it cook up? What does it look like in liquid forms? I was shocked the first time I saw a bright yellow colored solution because I've never seen that before. I've been doing drugs research for over 20 years. And this is a fentanyl salt, which is cooking up to be a bright, almost neon yellow colored, kind of disturbing. We're interested in how people use the drugs because not only are we studying overdose, we also want to study disease transmission like HIV. So we're interested in how people mix their drugs, prepare them, and how they inject them. This solution here is a clear solution, also very unusual. Heroin tends to be a nice tea colored, and here we have a clear white solution that was acting like heroin, but instead was a fentanyl salt. Here's a yellow person injecting a very mucky, muddy, blurry, yellow colored solution, which also is very disturbing. People like to have their solution, their drug solutions to be clear. We're also interested in the social aspects of drug use, both procuring it, sharing it, helping each other out, but in this case, also helping each other in terms of injecting one person, injecting another one here. So what did we find very briefly? This is a much longer talk. This is results that come from a number of papers that we've written. There's about 6 themes, but I'm just going to give you a couple of them, and then I'll summarize all 6. First thing we discovered, and this is a big deal, is that this fentanyl phenomenon was a supply-side phenomenon. Fentanyl was not the new party drug. It wasn't like people liked it, and that created the market. The market imposed itself on people. The fentanyl was being sold as heroin, and people used it when they bought heroin, whether they wanted fentanyl or didn't want fentanyl. There was a lack of information and choice then. So if you wanted to avoid fentanyl, you couldn't do it, or you found it challenging to do. There was also lack of knowledge among the street level dealers. So for example, Hector, he's been using for 20 years, and he's a user and a dealer. He says, we're supposed to be buying dope that doesn't have any fentanyl in it. But when I started showing up dirty with heroin, I started showing up dirty with fentanyl. When we cut the dope, we don't use fentanyl. The problem was that we were already buying the dope already dirty with that, and we didn't know it, which means it was being put in further up the chain of sales. This is a supply-driven phenomenon, which meant that people's expectations were not being met. They were surprised and often dismayed by having the substitution from heroin to fentanyl. To show that there's no interest or lack of interest in fentanyl, there was no cultural idioms, no slang for it. People like a drug. They develop slang for it. They share it with their friends, and then they start asking for that drug. We did not see that in the fentanyl phenomenon. We still don't see very much of that in fentanyl. And that led to polarized preference. Some liked it, some didn't. Here's Tim. He's been using heroin for 25 years in Baltimore. He likes it. The high is wonderful, he says. It's splendidly wonderful. It's magnified heroin by a great number. Rebecca, on the other hand, she's younger. She's only been injecting for 2 years. She's new to the scene. She doesn't like it. She says, I don't like the feeling of it. I don't like the high of it. I don't like nothing about fentanyl. In qualitative research, we get these quotes to kind of add richness to our stories. Theme 2, that these changes from the supply side imposition of fentanyl were rapid and changed the drug itself, whether it's heroin or fentanyl or a mixture of heroin and fentanyl, changed on a daily or weekly basis. It changed in the way the color of the powder, the color of the solution, the intensity of the drug effect in the body, the duration of the drug effect in the body, and the sensations that the drug effect had. Heroin in the United States traditionally comes in 3 forms. You see a black form there, it's black tar heroin, comes to California and other Western states. Brown powdered heroin took over the eastern part of the United States for well over a decade. And this white powdered heroin from Southeast Asia, the so-called China white, is a bit of a myth in our country. We haven't really seen it since the 1970s. What are we seeing now? We're seeing new white powders. We're seeing sandy browns and gray powders. And while heroin traditionally would cook up to a nice tea color, here we have these bright white powders that are coming out clear and bright yellow in solution. We were so curious about this variation and the changes, the vicissitudes in the colors of heroin, that we actually brought out paint swatches and had people point to what they were using. You see this whole palette of colors from white to light grays to light browns to yellows to medium browns to bright colors. Looks kind of interesting or maybe pretty, but it was disturbing to the users because they didn't know whether they were allowed to inject bright yellow heroin or bright blue heroin. And finally, the last one I'll talk about in detail, here's Jerry. He's a U.S. Army veteran, a combat veteran. He talks about the social devastation in his community. He goes, now the dope is fentanyl, and it's killing people left and right. I have over the years, I've watched friends die, but on average, it was 3 a year. Now, the last 3 years, it's been an average 20 per year. I feel like I'm back in a combat state, and I feel like I'm fighting for my life right now. Devastating. So in summary, multiple cities, multiple studies, multiple papers. Here's our ethnographic findings, qualitative findings. Changes in heroin were supply driven. There's variation in the potency, types of analogs, and mixtures that were seen out in the community. The devastation is widespread, both at the individual, social, and cultural level. There's mixed desirability for fentanyl. Even the latest studies show about 40% of heroin users like or prefer fentanyl. And there's some degree of discernment. I get to talk about this. I could talk about it in the questions and answers one, where people are able to detect that it's fentanyl or not heroin. And this has led to some organic precautionary strategies for people trying to keep themselves and their friends safe. And this knowledge is being transferred in the oral tradition. Harm reduction should listen to these adaptive strategies and create interventions. Briefly, before I end, I just want to talk about how addiction medicine, which is my field as a clinician, as a doctor, how it's changing. Over the generations, we moved from a moral or character-based understanding of addiction. People of poor moral character use drugs. We've moved from a choice-based, and people are simply making bad choices. Those are going away. And we increasingly understand addiction as a brain disease, as a disease that affects multiple parts of the brain that leads to deficits in motivation, deficits in learning and memory, and problems with inhibitory control, problems with executive functioning that says, no, I don't want to do that drug now. This new paradigm in addiction medicine says, yes, this is a brain disease with lots of evidence to support this now. It is a disease of motivation and insight, and therefore badgering people, forcing people to change their character or to change their behavior, to have different motivation, to have different insight, to coerce behavior change. These strategies often fail. What we need to do instead is adopt a medical model, a public health model, to build trust, build engagement with people, not judge them, not increase stigma, but to decrease stigma, invite people into care, keeping it positive, use incentives and rewards if you need to, okay? And bottom line, treat people where they're at, meet them where they're at. And that is the bedrock principle of harm reduction. So in conclusion, why do we do qualitative research? We want to engage with the community. We want to build that trust. We want to build a level of understanding that treats people as experts so that we can get better understanding of risk and risk-taking, so that we can build trust and undo stigma. We don't judge people. We meet them where they're at, principle of harm reduction. And if you do all that right, your research is not only improved, but your interventions will be improved because you can build bridges to community-based programs, from your street-level harm reduction program over to treatment and other prevention programs, other clinical interventions, right? And once people get there, because they've already engaged in a trustful relationship, you get greater acceptance, greater adherence to the things that you're trying to do to care for them. You get better buy-in. With that, I'll end. There's my lovely team again. I thank them so much for being part of this research, and I also would like to thank you all for your kind attention today. Thank you very much, and have a great summit.
Thank you so much, Dr. Dan. That was quite an informative presentation from the subject matter on opioid addiction, as well as the dangers posed by fentanyl and the communities that you work with. But my main takeaway really is the importance of qualitative research, particularly for communities that have always been marginalized, because this allows them to actually speak. And for researchers like you, like us, this actually gives us an opportunity to finally highlight, put the spotlight on the communities and how they their experiences are affecting them and how their insights actually now gets to be in the spotlight, what they think about their experiences. And I fully agree with the last slide that you presented about making sure that we're not just doing research because we're interested in what people are going through. We're interested in what they're going through because we can use research to develop better programs that goes back to the community and helps better the lives of the communities that we work with. So thank you so much for that.